platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I am your host, Dr. Elias Tadessa, co-founder and chief operating officer at Blue Health Ethiopia. We are honored to have Dr. Alberto Oviedo here with us to give us a brief discussion on bedside diagnosis of DVT. Dr. Alberto had been a senior consultant in the emergency and critical care service at the Valmy Hospital in Sevilla for 10 years. It has been 10 years since he began using ultrasound in different topics of emergency medicine and critical care. He is also an international trainer of World Integrated Network focused on critical ultrasound. He is also the team leader of the ultrasound group of the Spanish Ultrasound Society in Andalusia. He is also a professor in the Department of Medicine at the University of Sevilla in the subject of clinical ultrasound. He is also the coordinator of public health system for training in ultrasound for family and emergency doctor in Andalusia, Spain. And he is also an instructor at the International Trauma Life Support.
Thank you so much for the invitation. It's a real pleasure and honor to stay with you just a few minutes to talk about something that is my passion. Is the topic of ultrasound emergency and critical care. I have been working in this topic for the last 20 years, and this topic that we are going to talk today from DVT is, of course, ultrasound diagnosis of DVT, most of the cases in the emergency department. So this is a basic skills for the emergency physician at the 21st century. So it's really easy. I have, sorry for the delay in the seminar, and sorry for the technical problems that we have had. So I will do it my best to do shorter the presentation. So I don't like so much the presentations with so many letters, with so many sentences. So for ultrasound lectures, I prefer the really visual lectures with many video clips, and all of us can see the video clips. So the DVT and also the superficial venous thrombosis diagnosis by ultrasound must be be able to differentiate an artery from the vein. So it's not difficult, but we need to know the difference between the vein and the artery in an ultrasound scan. So the arteries are pulsatile. They are not compressible. That means that if I compress the artery, I cannot collapse totally the artery. And most of the case, when I compress an artery, I can check the pulse of the artery more easy. The walls of the intima and the media are clearly differentiated. So we must have a look always to the wall of the vessel that we are studying or we are scanning to be sure if this vessel is an artery or is a vein. So on the other hand, the veins never are pulsatile. They are not pulsatile. They are totally compressible. That means that if I compress with a probe, I will be able to collapse totally the light or the lumen of the vein. The echogenic, the wall are thin and echogenic, so that means that we cannot differentiate the walls, the intima and the media and the muscularis mucosa loy in the vein. And also, in most of the cases, we can see valves inside the vein. So if we are scanning vessel, we see valves inside the vessel. That means that it's always a vein, because the arteries never has valves inside. So if we welcome back to the previous slide, we can see two different vessels here. This one that is below, we can differentiate that in the wall. We can see three different layers. First one more echogenicity, with more echogenicity, more external hypoechogenic part of the wall, and the third one, a new hyperechogenic part of the wall. This means that we can differentiate the three layers of the artery wall. But on the other hand, in this part, this is a vessel. In this case, we are scanning longitudinally the internal jugular vein and the carotid artery in the neck of the patient. In this jugular vein, we only see in the wall only one line that is clearly with echogenicity. So that means it's white at the ultrasound scan. So this is the jugular vein, and this is the carotid artery. Okay. This is a different scan of the same region in the different patient. This is a transversal scan of the patient. We can see this vessel and this one. So this one has echogenicity. Sorry, it's pulsatile, clearly pulsatile, and this one is not pulsatile. This one we can differentiate the intima and the media and muscularis mucosa parts of the wall, and in this, the left one is not possible. So also, if we compress in this part, if the lumen of the vein is totally free, so that means that we can collapse totally the anterior and the posterior wall of this vein. So this is a main sign that we must to look for to rule in or rule out DVT or superficial venous thrombosis when we scanning our patients. So in this is an artery and a vein, and this is the probe. So if I compress with the probe properly, I can see that the artery is not able to collapse, but I can collapse totally this vein. So this is the most important thing in this scan for ruling deep vein thrombosis or superficial vein thrombosis, because if I cannot be able to collapse totally the vein, that means that there is something inside, and this something inside, it's maybe a thrombus. So when you are not able to collapse totally the vein, you must to think that in that region of that vein is a thrombus inside. In this clip, in the right side, we can see the internal saphenous vein, the femoral common vein, and the femoral common artery. So, like artery are more lateral than the vein, this is the femoral, also lateral is the femoral nerve. So that means that this is the left leg of the patient, and as you can see, if I compress here, I can collapse totally the internal saphenous vein and also the common femoral vein. So I'm sure that this patient, at this level, the patient hasn't any thrombus. So here in this region, we can rule out the DVT. On the other hand, in this picture, this video, you can see that we have three vessels. The left one is the artery. Just in the middle is the femoral common femoral vein, and in the right side is the internal saphenous vein. I'm compressing with the probe but it's not possible to collapse totally the vein. So that means that this patient has a thrombus in the common femoral vein and also in the internal femoral vein. As you know, the internal femoral vein belongs to the superficial venous system. But when the internal saphenous vein has a thrombus really close to the common femoral vein, you must treat this patient as a DVT because has a high probability to do a thromboembolism. So, for the scanning the patient, we must know different things. First, patient position, which probe we must to use, the position of the probe, where we must to, in which region we must to scan. We must to know, as now all of us know the completion technique. If you are not a beginner with ultrasound, you can also mention other signs of superficial ventricular patency. Ultrasound, how ultrasound the common femoral vein, how ultrasound proximal ultrasound the superficial femoral vein and superficial femoral artery because they are together. And finally, ultrasound of the popliteal vein. Continue with, we will continue and show some difficulties that we have we can have with the patient when we perform ultrasound scan to rule out or rule in DVT. And finally, we will do a summary. So about the patient position, this is really important because the patient position allow us to do a proper examination of the patient by ultrasound and expose the vessels from the internal position to the anterior position, and it's really more easy to scan the patient. So most of the cases, if we can, it's better put the patient in anti-trend position because the hydrostatic pressure of inside the vein of the legs will increase. So with the diameter will be higher. So it's more easy to see something that is big than something that is thin. And the other important things relative about the patient position is the position of the legs. When we scan a leg for rule out or rule in DVT, the better position is like this. So it's a mild flexion of the hips and a mild flexion of the knee. And of course, an external rotation of all the legs. So this position transfer the vessel from the internal position that is usual to the anterior position, and we can scan more easy. So like this. This is in my hospital, two pictures in my hospital in the right side. So I'm scanning this patient for rule out or rule in a DVT. We suspect for any, I don't know why, DVT, and we scan at the first stage, scan as proximal as possible, but remember this position of the leg. Mild flexion of the hip, mild flexion of the knee, and also a good external rotation of the leg. And for to scan the popliteal vein, I prefer this position of the patient, if the patient can do it, because sometimes at the emergency department or in critical care patient, we cannot, many times we cannot move the patient. So my first option, if the patient can collaborate with examination, is put the patient, change the position of the patient from supine position to prone position, and put the foot that I want to scan, on the foot of the leg that I want to scan over the another foot. So this increase the hydrostatic pressure inside the vein and the popliteal vein, and makes me easily the exam on the scan of the popliteal vein. But if it's not possible, it's really common in critical passing, I must introduce the ultrasound probe just below to the popliteal fossa and scan like this the popliteal fossa. That is more uncomfortable for the operator, for the examinator. At least this is my opinion. Probe selection. Which probe we will use? So, many of the cases, we have two different probes in the different ultrasound devices that we have at the emergency department. The left one, this one, is a high frequency probe, and this one is a curvilinear probe. So this is a low frequency probe. The low frequency probe is able to go deeper during the examination to 15, 20, 25, 30 centimeters. And this one, on the other hand, the linear probe, the high frequency probe, doesn't allow you to go so deeper. So this is the best option for scan something that is superficial in the patient as vessels for DVT. For most of the cases that we need ultrasound guidance procedures, for soft tissue scan, for musculoskeletal scan. So we need for all of this, all the scan that we need to do that the structure is really superficial for 6, 8 centimeters normal. We can use this one. We must use this one because this kind of probe with high frequency shows you a better image of the skin. But the problem, as you know, is the depth that you can work with this one. So for superficial, this one. For deeper examination, deeper scanning with ultrasound, this one. So 98, 99% of my patients, I can do the scan with this one, with a better image at the screen, and it's enough the deeper that this probe offers us to scan the patient. But in a few patients that they are really obese, we must use this probe to give you more deeper to work with the patient to scan the patient. So remember, most of the case, more than 98% maybe, we need to use the high frequency probe or the linear probe. It's the same. About the probe position. First, we need to apply the appropriate amount of gel to the probe. Not too much, not too less. It's enough. We only need the amount of gel that allows us that the ultrasound beam penetrates properly in the patient. So that means that we don't need a big amount of gel, because if you use a lot of gel, most of the gel will go to the upper part of the probe, mix with your fingers. It's like water, and you will be comfortable because the probe will sliding from your hand, and you cannot scan properly the patient. So first, we always scan transversally to the vessels, not to the patient. In transversal position to the vessels. And it's a basic rule in ultrasound scan that always we must scan perpendicularly to the structure that you want to scan, to allow the device show you the best quality of image in the screen. So we will start the examination as proximal as possible. So as proximal to the inguinal ligament as possible, and sometimes just above the inguinal ligament. So, we will talk about that in a few minutes, but remember that we start the examination as proximal as possible. Many times we start scanning the end of the iliac vein and iliac artery, and after they cross the inguinal ligament, change the number to common femoral vessels. So when we are as proximal as possible to the inguinal ligament, we can differentiate, we can look for the vessels. And after that, when we found the vessels, we must to differentiate the artery and the vein. And now you know how to differentiate the different vessels, the artery and the vessel, and the vein. Remember that the artery are pulsatile. The artery has 3 different clearly layers in the wall, and we cannot collapse the artery when we compress. On the other hand, the vein are not pulsatile, are totally compressible. If I compress, I press, totally collapsible with the probe. We cannot see the 3 different layers on the wall. We can differentiate only one echogenic layer, and the vein also has valves inside the artery. So when we differentiate the vein and the artery, slide a little bit caudally to identify how the internal surface vein goes and empties into the common femoral artery. Sorry, common femoral vein, this is a mistake, sorry, really mistake. The internal surface vein empties into the common femoral vein. So after that, we compress and rule out or rule in DVT at this level. Remember that we must to collapse totally the vein to rule out the thrombus. And in this level, we must to rule out thrombus at the internal surface vein and also the common femoral vein. After that, we slide and scan a little bit more caudally and go to the area where the superficial and the femoral veins join, the junction of the 2 vessels, to the 2 veins. And after that, we must to compress again, see the collapsibility of the 2 veins, and rule out the thrombus inside this vein. After that, we continue distally, caudally, scanning and compressing each 1-2 centimeters, following the superficial femoral vein. Finally, we must to scan the popliteal fossa, to scan the popliteal vein, also transversally and with compression. It's the main sign to rule out ruling DVT. 1 minute to remember that when we need to scan and we need to compress a vein to rule out ruling DVT, it's mandatory do that in transversal position, not in longitudinal position. Because if you scan in transversal position, you only, if the patient has a thrombus inside the vein, you only move a little part of the vein. And it's really difficult that this thrombus go away to the heart. But if you compress in longitudinal position, you are moving a wide part of the long part of the vein, and it's easy that you move the thrombus and you do a thrombus volume to the patient. So these are static image. So at the first level, as proximal as possible, and if you can, just above the inguinal ligament, you must to look for these 2 vessels. This is the inguinal ligament, and look for these 2 vessels. This is the first step. and you must to compress and differentiate the artery and the vein. After that, slide a little bit more caudally to identify how this vein, that is the internal saphenous vein, empty in the common femoral vein, and this is the common femoral artery. So if I do a compression here, I must to compress these two vessels, these two veins totally. And this image, this view at this level is called the Mickey Mouse. The Mickey Mouse, where the face of the Mickey Mouse is the common femoral vein, the right ear of the Mickey Mouse is the common femoral artery, and the left ear is the internal saphenous vein. After that, we continue scanning only the superficial femoral vein, because the deeper femoral vein go so deep and is not able to scan properly. So we only scan the superficial femoral vein until the ends in the hunter range close to the knee. So we can scan caudally, scan, compress, go caudally a little bit, compress again, and rule out the difference parts in this vein. You must remember that in this position, the artery is always superficial and the vein is always deeper. So this vessel is the superficial femoral vein, and this is the this superficial vessel is the superficial femoral artery, and this one that is deeper is the superficial femoral vein. This is the vein. So if I compress here, this vessel that is deeper must be collapsed totally. And finally, we go to the popliteal fossa. In the popliteal fossa, we scan from the back to the anterior part of the leg. So it's like these two vessels are scanning from this part. So the first vessel we will see is this, that this is the vein. So from the back part, this is the vein. That's in this part, in the popliteal fossa, the more superficial vessel is the vein, and the deeper is the artery. So popliteal vein and popliteal artery. And in this case, if I compress properly, this vessel, the superficial, the popliteal vein, must be collapsed totally. So remember that we are scanning from the most as proximal as possible, and each scanning we must to apply a progressive but firm compression until total collapse of the venous lumen that we are scanning. So the lumen must be disappear completely. If you cannot collapse totally the vein, you must to think that the inside the vein there is something, and this something is the clot of the thrombus. So and the clot of the thrombus may be seen sometimes with some echogenicity. So the acute thrombus has no echogenicity; it's totally black. So in acute thrombus, you will not be able to see some echogenicity of the thrombus inside the vein. The only sign that you will find is that it's not possible collapse totally the vein. So, and remember, we only perform compression in transversal view, never compression in longitudinal views to avoid thromboembolism in the basin. So this is the compression technique. Now this image is at the level of the Mickey Mouse. So this is the femoral nerve, this is the common femoral artery, the common femoral vein, and this is the internal saphenous vein. As you see, if in this person I'm compressing, I can collapse totally the vein. So that means that they rule out totally DVT at this level. But in this case, it's different. I'm compressing, but I'm not be able to collapse totally these two veins. So that means that we have a thrombus in the internal saphenous vein, and also we have a thrombus in the common femoral vein. And if you look at the vein, there is something with echogenicity here, and something with echogenicity here in the internal saphenous vein. This is the thrombus. When the thrombus is really acute, it's totally black. When she's getting older and has a few years old, a few days old, you can see with more echogenicity, and the thrombus has a few weeks old, so the echogenicity is increased. So in chronic thrombus, most of the cases has real echogenicity, and it's really easy to identify, but because they has a clear echogenicity, and you can see something white inside the lumen. Also, if you are not a beginner, you can look for other signs of permeability, but this is not as important as the collapsibility of the vein. The most important sign to assess the permeability of the vein is the collapsibility of the vein when you compress. So, but if you know how to use the color Doppler, you can do it. You can use the color Doppler. Also, if you know how you can use the continuous Doppler, you can use continuous Doppler. So, in this case, we see that the flow fills totally the lumen of the three vessels that we are scanning. So if we have a patient that has a thrombus in the vein, a part of the vein is not filled with the color flow like this. But I said before, it's not so important. For beginners and for experts, it's most important the assessment of the collapsibility of the vein when you compress with the probe. Okay, so this is a scheme of the vein anatomy in one leg of the patient. So remember that we have talked that we must scan as proximal as possible at the inguinal ligament, and if we can, a little bit more proximal than the inguinal ligament at this level. And in this level, we must look for the two main vessels that we can see here and identify properly the artery and properly the vein. So in this case, this vessel that is in the left side is the artery, and this vessel that is in the right side is the vein. Because when I compress I do a compression with the probe, I can collapse totally the vein. But also, I can see that the artery is pulsatile. So that means that if I collapse totally the vein, that means that I rule out deep vein thrombosis at this level in this patient. On the other hand, some patients we can see that when we compress, we cannot compress properly totally the vein like this. And also, the diameter of the vein is increased because this is a secondary sign of the DVT. The diameter of the vein with DVT increase because the pressure that the vein has inside. And also, in this patient, we see a secondary sign also, that is the echogenicity inside the vein, that is the thrombus. This thrombus is not totally acute, it's not for the last 24 hours. So after that, we slide a little bit caudally the probe, also always in transversal position, remember, like this, and go to the junction of the subfemoral junction, where the internal subfemoral vein empty in the common femoral vein. And here we have to assess the Mickey Mouse. Remember, the Mickey Mouse is the Mickey Mouse. The face of the Mickey Mouse is the common femoral vein. The right ear of the Mickey Mouse is the artery, the common femoral artery, and the left ear is the internal subfemoral vein. And at this level, we must scan the two veins, the internal subfemoral vein and the common femoral vein, and we must to check that we can collapse totally the vein when we compress with the probe, as we can see now. But sometimes we scan the patient that has thrombus inside, and we cannot collapse totally the two veins. In this case, the common femoral vein, that is just in the middle of the image, is don't collapse totally, and also we can see something with echogenicity inside. So we have the main sign, that is we cannot collapse totally the vein, and the secondary sign, that is the echogenicity inside the vein. And also the same with the internal subfemoral vein. We can see something with echogenicity, it's a mild echogenicity, but we can see something with echogenicity inside the internal subfemoral vein, and also we can see that we cannot collapse totally the vein, the internal subfemoral vein. So this the first as proximal as possible, the second at the subfemoral junction. After that, we must scan all the superficial femoral vein. At this level, remember that the artery is superficial and the vein is deeper. It's like a number, like an 8. And if I compress, I must compress to collapse totally the deeper vessel, that is the superficial femoral vein, like we can see here, the deeper one. So we can compress. So a tip for scan this part, the superficial femoral vein, is that you must be properly perpendicular to the vessels. If you are not properly perpendicular to the vessel, it's more difficult to collapse the vessel, and you can make a mistake and think that the patient, I cannot see that this vein collapsed totally, so the patient has a DVT at this level. But it's a problem with the technique. So remember to scan totally transversally to the vein in the properly position to avoid that mistake. Some patients, how we can see in this level a DVT, because most of the cases, so the absence of collapsibility, total collapsibility of the vein when we compress, and we can see also secondary sign as echogenicity inside, increase of the width of the diameter of the vein. We can see the echogenicity inside. And if you can or are familiar with the color Doppler, you can use the color Doppler. Also, if you are familiar with the continuous Doppler, you can use it. And in this case, we can see the number 8, the superficial is the artery, the deeper is the vein. We can see that the deeper has a increased diameter. We can see also that there is something with echogenicity inside, and we can see that we cannot collapse that vein. So we have a primary sign and a few secondary signs that this patient has deep vein thrombosis at the level of superficial femoral vein. And it is the diagnosis. We don't need anymore to say that this patient, to rule in a DVT at this level in this patient. So after that, we must go and scan the back of the leg at the level of the popliteal fossa to scan the popliteal vein. Remember that in this level, we are scanning from the back to the anterior part of the patient. So here the vein is superficial and the artery is deeper. So if I compress, I will collapse totally the superficial vessel at this level. This is the vein, the superficial vein, and this is the artery, popliteal vessels. How can we see a DVT at this level, like this? We can see that the diameter of the popliteal vein is higher, is increased. Also, we can see that there is something with echogenicity inside, that is the thrombus, and also we can see the primary sign, that is that we cannot collapse totally the vein when we compress with the ultrasound probe. So, after that, we have finished the scan and rule out or rule in the different levels where a clot can be in the legs of the patient. So, why is this enough to rule out or rule in a DVT in this patient? Because now, well, not now, a few years ago, we know that 10% of the patient affect only to the popliteal vessels. So if we scan here, we can rule in or rule out 10% of the popliteal DVT, or the DVT of the leg of the patient. 42% of the patient affected to the popliteal vein and also to the superficial femoral vein. 5% affected also the common femoral vein. 35% of the patient affect all the proximal vessels, all the proximal veins. So affect the popliteal vein, superficial femoral vein, the common femoral vein, and the iliac. And also, 8% affect only the common femoral vein and the femoral superficial or the iliac vein. So if we scan in this patient at this level, and at this level, we can rule out or rule in almost 100% of the patient. So this is the main important thing, to be sure that we are doing a proper technique to the patient. So this is the thing that say that we are doing the things in these cases properly. So sometimes we found difficulties to scan the patient or to go to a proper diagnostic with the patient of DVT. Where we can have, or the patient can have hematomas or fibrillar breaks that can mimic during the examination a DVT properly, or cellulitis or edema, that can mimic a DVT when you have a look at with the eyes to the patient. Some fractures, Baker's cysts, and also a rupture of Baker's cysts can mimic a DVT. Some lymphadenopathy can press the vein and has a similar view of the DVT. So, and we must be able to differentiate these different problems from a DVT in this patient. So, this is how a huge hematoma, a superficial hematoma between the subcutaneous tissue and the muscle. This is the muscle, and this is the subcutaneous tissue. This is a hematoma in a patient that was using low weight heparin in the legs. They was referred to my hospital to rule out DVT. But if the family physician trained in this way, he can rule out DVT or rule in DVT by himself, and it's not necessary transfer the patient to the hospital. So this is different kind of hematoma because this is intramuscular in the anterior rectus muscle of the leg. This is the how can we see, and this creates that the legs of the patient is thick and maybe is painful. Also, in the calf. The calf, this is an internal gastrocnemic muscle. This is the soleus muscle, and this we can see a break. This is really common that in my setting, in my area, that the family physicians send us this kind of patient because they think that the patient has a DVT, as it's only a fibular rupture of the muscle with a hematoma. This is a different hematoma between the internal gastrocnemic muscle and the soleus muscle. Between that, we have the hematoma, and also we can see that the hematomas, in one part of the hematoma has organized in a thrombus. Not in a thrombus, sorry, in a clot. So it's organized, and the black side is more fluid, and the clot has more echogenicity. It's important to differentiate this part, because if you want to evacuate or drainage this hematoma, and this hematoma has already been organized, is not be able to evacuate. So first see the hematoma, check the hematoma. You must to be sure this is totally fluid, and if you are sure, you can drainage this hematoma, because if this hematoma is now a clot, is not be able to remove it. So this is how cellulitis and edema looks like by ultrasound scan, like this, like stones, like stone with a little fluid inside the stone in the subcutaneous tissue. This fluid, this black part that this black layers that we can see in the subcutaneous tissue is not be able to be drained. We can see the black, but don't try to drain this, because it's not possible. We cannot be able to drain this. This is a tibial fracture of the patient that was sent to the transfer to our hospital to rule out DVT. But when I scan the patient, the Spanish say, no, but my pain is here, it's in the ankle. So I scan and I see properly the fracture here. Also, I scanned all the vessels and rule out DVT in this patient. This is how Baker's cyst looks like in the popliteal fossa. This part, just between the semimembranous muscles and the internal gastrocnemic muscle, it's like a black bag, just a black cyst inside. It's really easy to learn how to differentiate the Baker's cyst by ultrasound, and sometimes this Baker's cyst rupture and dissect the caudally the subcutaneous tissue from the gastrocnemic muscle of the calf, and it could mimic a DVT clearly, but it's really easy to rule out the DVT with the ultrasound scan, and after that do the proper diagnosis to this patient. And here is how looks like a lymphadenopathy at the inguinal level of the patient. Here on the artery. So you can see that it's pulsatile, and sometimes this kind of lymphadenopathy press not the artery, press the vein, and can originate the increase of the width of the lymph, and can mimic a DVT. But sometimes by compression, not because the patient has a DVT. The increase of the thick of the patient. So, and you know how to use the color Doppler in the lymphadenopathy is really useful, because here we can see that the flow is typical of the reactive lymphadenopathy of this patient. So, in summary, and finally ended the seminar, you must know the pathologic findings related to DVT. So, the main sign to rule out or ruling DVT is echo compression. So if you can collapse totally the lumen of the vein with compression, you can rule out DVT at that level. But if you are not able, or you cannot, it's not possible to collapse totally the vein, so you must to think that the patient, and you can diagnose that the patient has a DVT at this level of the vein. Sometimes you can direct visualize the direct visualization of the thrombus, because we can see the echogenicity like this, in this case, inside the common femoral vein. If you are familiar with the color Doppler flow, you can use it. Also, you can use the pulsed Doppler if you are familiar with it. But the primary sign is that you cannot collapse properly and totally the vein when you compress. So, and here we will show you different cases of DVTs at different level. This DVT at the iliac level. So the left vessel that we can see has increased the diameter. We cannot collapse properly the vein, and also we can see something with echogenicity. And in the right picture, we can see that this vein has no color Doppler flow inside. So this means the main sign and the secondary sign. So we can be sure to diagnose this patient of DVT at the iliac level. At the femoral level, femoral junction, we can see the same. Is always the same. If you can or you cannot collapse totally the vein, if you can see something with echogenicity inside, if you are familiar with the use of color Doppler, you can use it, and you can see that with color Doppler, the patient hasn't any flow inside that vessel that are affected by the DVT. Here we can see how saphenous internal vein thrombosis looks like by ultrasound. It's the same, and the diagnostic is the same. We assess the collapsibility with compression. We assess if there is something with echogenicity inside. If you want, you can use color Doppler or pulse Doppler to assess the flow inside the veins. Also, the same in the femoral veins. The common femoral vein has increased the depth, has increased the diameter, has something with echogenicity inside, and we cannot collapse properly with the compression, and has no flow with the color Doppler flow. Here we are scanning the superficial femoral vein with the artery is more superficial and the vein is more deeper, and we can accept that the vein has increased the diameter, has something with echogenicity inside, and we cannot collapse totally the vein. And also in the right picture, has no flow inside the vein. And here at the popliteal level. So remember that at the popliteal level, the vein is superficial and the artery is deeper. So we can, in the left picture, we can see the increased diameter of the popliteal vein, and we can see also that we cannot collapse totally the vein with the compression. And the right picture, you can see that we can see the flow inside the artery, but there is no flow inside the vein. So, and here is how it looks like a DVT from the passing of my hospital. Okay. Now, so remember that in the saphenofemoral junction, we must assess the two veins, the common femoral vein and also the internal femoral vein. So remember that it's called, in the common language, Mickey Mouse. It's called the Mickey Mouse. This is a thrombus in the superficial femoral vein. We can see the two vessels, the the superficial femoral artery is more superficial than the superficial femoral vein that is deeper, the diameter is increased. We can see that has echogenicity inside, and also is not. We cannot collapse the vein with the compression. Sometimes we have a look longitudinally to the vein, only to have a look in the two views of the pathology of the patient, but never do a compression in longitudinal view. Only is for scan, not for compression, if you want. So here you can see how in the same patient the color Doppler show you that there is some parts of the vein that are not refilling for the flow, are not refilling with the flow of the vein. So in this part with no flow, we have a thrombus. So also at the level, we sometimes we can see that this superficial vein, that is the internal saphenous vein, is normal, but here, more deeper, we can see the superficial femoral artery and the superficial femoral vein, that the vein has increased the diameter, has echogenicity inside, and we cannot collapse properly with the compression. And also at this level, in this patient now, we are at the popliteal level, because remember that at this level, the popliteal vein is superficial, and most of the time, we can see also the bone here. So with this, we finish the seminar. Thank you so much for your attention. Thank you so much. Thank you so much for your patient to be patient, because we have had a few technical problems to start. I'm really happy, and it has been a real honor to stay here with you. I hope we can do it in the close future. So with this, we can finish.
Thank you, Dr. Alberto.
Okay, I give the floor to you. Thank you so much.
Yeah, it was a great presentation. So now the floor will be for the audience. If you have any questions, you can ask on the chat box, and Dr. Alberto will give an explanation to the questions. There was a question that asks us, what is winking sign in DVT?
King sign, the primary sign, the main sign. The main sign is the vein. We can collapse properly the vein or not collapse. So if we cannot collapse properly the vein with the compression, is the main sign. It's enough. With that, it's enough to rule out or rule in DVT at the level that we are scanning. Of course, we must scan all the regions that we have been talking the time before in the seminar, in the lecture.
Yeah, he also asks us what's collateral in DVT?
Collateral DVT. No, I think that this doctor is talking about superficial vein thrombosis. Yes, I don't know the concept of collateral DVT. The collateral DVT, the DVT is only DVT. It affects only the main veins that we have been talking about. So I think it's talking about the superficial vein thrombosis. And to rule out superficial vein thrombosis, the technique is the same. It's simple. Only compress and assess if you can collapse totally the vein or not totally. If you can collapse the vein in a superficial vein, there is no thrombo, there is no superficial vein thrombosis. If you cannot collapse a superficial vein, you must accept that this patient has a superficial vein thrombosis.
Great, Dr. Alberto. So, is there formation of collateral in DVT?
Sorry?
Is there formation of collateral in DVT? Yeah.
Not formation and collateral. Sometimes you have a thrombus in a part, for example, in popliteal vein, and the thrombus increased the size and affected the proximal veins, but not collateral. Sometimes some superficial vein thrombosis can create a DVT, but it's mainly in the more proximal saphenofemoral junctions. So the 5 centimeters, if you have a thrombus in the first 5 centimeters of the internal saphenous vein, you must treat the patient as DVT, because now we know that this kind of superficial vein thrombosis has a high probability to convert in DVT and affect the common femoral vein and create a thromboembolism. So I think am I answering the question? Okay.
Yeah. Thank you so much, Dr. Alberto. So you can say something.
Something.
I'll give you a chance to. Yeah.
Okay. No, so the same. It's a great honor to stay here with you, share our announcement between Together and Learn Together. So thank you for the opportunity. Thank you for the invitation. I would like to repeat this opportunity in the close future. I will be in close contact with Dr. Nathan. Thank you, so Dr. Nathan is close to me. So in the close future, maybe we will share a few minutes talking together about some ultrasound topics in the emergency department. Thank you so much.
Thank you, Alberto. It was a great presentation. It was a pleasure for us to have you here, and I hope, as you said, like we will have another sessions again. So I wish you all the best. Stay here in Harar, Ethiopia. So we will communicate again. So thank you so much.
Second hello. Thank you so much for everyone. See you soon.
Thank you.